Welcome all. I'm Qazzafi, microbiology consultant and deputy DIPSI, and I'm accompanied today with Lesley McKay, our associate chief nurse for infection control. We're going to talk about something different than COVID this time. We did present GNBSI, that's gram-negative bloodstream infection, grand round back in 2018, and this is actually an update on the same. So the plan would be that I would talk about GNBSI epidemiology and some national and regional data. Then Lesley will present local data and ward level information. Then I'll take you through the revised UTI pathway and a couple of mini audits. You can ask questions by using the chat box function. We'll try to answer your question at the end of the presentation. Next slide, please. Okay, for reporting and performance management purpose, GNBSI include E. coli, Klebsiella species, Pseudomonas aeruginosa. The majority of these infections are community onset. All three bloodstream infections are notifiable to UKHSA, which used to be called PHE, via a specific data capture system. So E. coli from 2011, Klebsiella and the Pseudomonas from 2017. Next slide, please. So what's the trust apportion is slightly complicated. There are certain definitions to use. Basically, trust apportion cases include those occurring after 48 hours of admission, and these will be categorized as hospital onset, healthcare associated or HOHA, and then those which happen within 4 weeks of discharge from hospital, and these are called as community onset, healthcare associated or COHA. So both HOHA and COHA are our numbers, and these are really important because these same definitions also apply for some other organisms like C. diff infection as well. Thank you. Next slide, please. So what's so important about GNBSI? GNBSI is likely associated with around 5,500 deaths each year and costing NHS a very significant money. Next slide, please. So the age is an important factor for GNBSIs. In over 85, the risk of E. coli bacteremia is 824 per 100,000 population as compared to 70 per 100,000 population for other people. So as I mentioned, around 70% or more of these infections, they are community cases. Next slide, please. Okay, so sorry, just 1 second. Yeah. In terms of the trends, they are not very encouraging. So as a whole, E. coli, there is a rising trend. So bacteremia continually rising until pandemic, but again having upward trend again. Next one, please. Pseudomonas aeruginosa again overall upward trends. An increase was observed during the second wave of pandemic, but not clearly why it was like there was increase. Next one, please. Klebsiella even more significant rise in numbers, and in fact, rates and accounts from the pandemic time are highest since the start of the mandatory surveillance. So you can see from 2017 to 2021, there has been nearly 30% increase in the count of all reported Klebsiella species, bacteremias, which was from 2,348 to more than 3,000. Next one, please. So in terms, I have put all the graphs here, the three like from the Cheshire and Merseyside data, so which again showing rising trend, especially for hospital acquired cases for all three bacteremias. Next one, please. In terms of mortality, as again, you can see the graph, mortality for both Klebsiella and Pseudomonas is slowly rising. This is the gray and the amber dotted line. You can see it's slowly upward trend. Next one, please. This is interesting graph again. So for Klebsiella bloodstream infections, 30-day mortality for hospital acquired cases is continuously rising. It's not clear why, but seems like there's a Klebsiella carries high mortality in patients with malignancy or alcoholism. Next one, please. Okay. So you may have already seen this requirements. So this government paper came in 2017 asking for reduction in the GNBS size by 50% by 2021, which was later revised and the new target date was given. And now we are required to reduce the GNBS size by 50% by end of the March 2024. Okay, so for the trust, it's a really important. It's like a trust quality priority. Next one, please. Okay, so the overall, the national, what's the like its source of infections are. So typically urinary tract is the main source, but other like sites like a hepatobiliary, gastrointestinal, IV devices, skin and soft tissue infection, and respiratory tract, they all could be important. Okay. Yeah, next one. Thank you. Okay, so although urinary tract is the main source, but as I said, other source important. And the can you just move on to the next one, please, as well here? Yeah, so this is the hepatobiliary. So this is in terms of from this source, this article was published in Journal of Infection Prevention, highlighting how to prevent or minimize GNBSI in hepatobiliary surgery cases. Various things they have been mentioned there. So by performing early surgery or early biliary stenting, or by using metal stent instead of like a plastic ones, or can help reduction of the infection and bacteremias. So we will have some discussion with our gastro colleagues to see how we can implement these changes. Okay, thank you. Next one, please. Okay, I'll pass on to Lesley McKay for some local data and the world level information.
Thank you. As Samantha mentioned, we have contractually set thresholds for the gram-negative bloodstream infections now, just in the similar way that these thresholds were set for MRSA bloodstream infections and Clostridium difficile, and they still stand. At the minute, there are no contractual penalties for not meeting the gram-negative bloodstream infection threshold or targets if we exceed them. But so that's a possibility that may occur. This is the data from the last financial year. So what you'll see just on the first graph on the left-hand side of the screen is the data by month over the financial year. And what we've done is separated out those hospital onset cases from the community onset healthcare associated cases. So if you remember from Zaman's slide earlier, that's patients who've been discharged and then been readmitted within 28 days and may have tested positive within the first 2 days of admission. And it's important for us to separate those out because we needed to compare like for like. So if we looked at our data for last year compared to the year before, it looks like we've gone up by 20 cases, but the way the cases are apportioned to us changed. So in terms of the E. coli thresholds for last year, we did reasonably well. So we came in at 63 cases, combining both those two categories of cases against a threshold that was set of 81. So to meet the national reduction target that the man was talking about of 50% reduction by 2023, we've been set a certain percentage reduction year on year. The graph at the top right hand corner just shows our cases by location. So you might see some unusual locations there like frailty, catheter lab and ophthalmology. So when the patients have been into those areas, they've had an admission stamp and then possibly come back a few days later or within 28 days, and then we took the samples from there. And what you can see there is some wards with more combined numbers of cases than others. So B19, obviously care of the elderly ward, and A8, higher numbers of cases. So bottom left-hand corner, you can see there quite clearly displayed that most of the cases, so of the 63 cases, 30 of those were associated with UTI. So we definitely need to focus around UTI, and obviously we'll move on to talk about the revised UTI pathway shortly. And then if we look at the split by ward of the likely primary cause, we can just see 2 wards there again, possibly due to the comorbidities associated with the patients on those wards, but A8 and B19 both had more urinary tract associated gram-negative bloodstream infections than some of the other wards. And one of our plans moving forward this year is to do just a bit more focused with those 2 wards. Next slide, please. So again, similar graph for Klebsiella species. Our threshold for Klebsiella was 23, and we exceeded that threshold by 3 cases. So Zaman's looking at an audit of those cases so we can try and identify any further learning. Again, most of them are associated with the urinary tract, as you can see in the bottom left-hand graph. And you can see again the split by ward there. but nothing particular standing out for us to go and pinpoint as a focus, as we saw with the E. coli graph before. Next slide, please. And Pseudomonas, slightly lower case numbers, so our threshold was 4 and we ended up with 3 cases at the end of the year. And again, so 2 of those out of the 3 cases were associated with lower urinary tract infection. Next slide, please. So what we've been trying to do, we've had different approaches to how we've been trying to tackle the GNBSI programme. So initially we came down with a top-down approach using a toolkit that's published by the Department of Health, looking across some basic elements of care such as hydration and hygiene and catheter management. And we didn't feel like we were making much progress with that approach, and obviously just bearing in mind the business of the ward environments as well. So we took a different approach and joined with our Quality Academy colleagues. We tried a bottom-up approach with standard setting. And at the point we were launching all of this, COVID hit. So we were looking, you remember Zaman said most of these cases are community onset as well. So the hospital case is probably about 25%. And around 75% community onset from our total numbers. So we'd started some work to look at standard setting at the ward level, and we focused on 5 major areas. So obviously we've looked at hydration, and we're looking for further evidence base around well hydrated patients preventing UTI. We're looking at continence management and trying to avoid catheters. So we were aware from some safety thermometer data that we had higher urinary catheterisation rate than other trusts. So we did a lot of work around trying to prevent people putting catheters in unnecessarily, looking for alternative ways to measure urine output, but also where catheters have been used to take those catheters out timely as well. Had a big focus on hand hygiene, and not just for staff and not infection control. We always talk about staff hand hygiene, but with this particular initiative we were looking at patient hand hygiene. And also we've got a focus on UTI detection and management. The thresholds this year, you can see just from the top left of the screen, a lot tighter than last year. So Klebsiella, bearing in mind we were over threshold at 26 cases. That target is quite challenging for us this year at 19. So we do need to drill into last year's cases and just apply any learning we can from those. E. coli again, so slightly lower number. I'm not quite sure why, but the Pseudomonas targets increased slightly. So just going back to UTI detection and management, one of the things we've tried to look at is just revisiting our UTI pathway. And I'm just going to hand back to Zaman now just to talk about the revised pathway. Thank you.
Thanks, Lesley. Yeah. Great. So the UTI pathway, which is revised now, this is not the new one. Obviously, we had for some time, but this is like an updated version. So this perhaps maybe provide more clarity on specific areas. So basically, it's like a UTI is about symptoms of like, various like a dysuria or frequency and urgency and all those things. Yeah. So, but more emphasis is on people who are 65 or old, because many of them, they can carry like an organism in the urinary tract called asymptomatic bacteriuria. So for them, the symptoms are the most important thing there really to diagnose a UTI. So dipstick testing is not appropriate because as I said, they would be having, some of them having asymptomatic bacteriuria. So dipstick may give you false positive result. So in people 65 and above, no dipstick testing should be done. Send urine for cultures if suspected UTI based on specific symptoms and start treatment empirically. Okay, so for next slide, please. The UTI, so symptoms are really, so one symptom, which is the main one called dysuria. So like, then, or there'll be a combination of 2 or more of the following, which are temperature, which is more than the baseline, new frequency or urgency, new incontinence, new or worsening confusion or delirium, new suprapubic pain, or visible hematuria. Combination of these two or more, that would be a UTI as well. Thanks. Next one, please. Yeah. So catheter-associated UTI, that's again one of the concerns, how we are managing them. So we have provided definitions in the antibiotic formulary what a COTI should be. So catheter urine should not be dipstick, but again, people are obviously doing dipstick on the catheter because all the catheters, they will get colonized with organism at some point. So there's some evidence that every day, 5% chance of a catheter getting colonized. So by day 25, 30, all catheter will grow an organism. So dipstick will pick those like indicators there. So that's really not a UTI, it's a catheter colonization only. So basically, again, catheter urine should not be dipsticks, and the CSU should only be sent for culture if specific symptoms of COTI, which are again described here. But it doesn't really happen all the time, so that's really we need to look into. So we did a mini audit. Akash, one of our like a junior, did the audit. Next slide, please. You can see this is a very mini audit over last just a couple of months. So 18 samples of CSU were looked into, and the 3 of them they had dipstick done, and in 4 of them there was no a really requirement for testing, but it was they were tested. And then also you can see the red line there, CSU sent as a per medical plan, but in absence of any a rate inflammatory markers or symptom, we just tested in case or scenario. So really need to look into how we managing the catheter UTIs or catheter urine samples. So again, there's a guidance in the antibiotic formulary on what COTI should be from definition. Yeah. Okay, thanks. Next one, please. Yeah. So the next part of the pathway is the upper UTI or pyelonephritis or sepsis of urinary origin. Again, this is something I'll talk in the later slide. Really important to differentiate between a UTI. Now, UTI is an umbrella term, I know, but UTI generally is synonymous with cystitis, like a lower tract, symptom, just a UTI. But urinary sepsis or sepsis of urinary origin is different. So that should be labeled accordingly, not just UTI. So the slide later on just to explain what that really means. So basically, if sepsis, do appropriate investigation, including blood culture, and start antibiotic as per the antibiotic formulary for sepsis of urinary origin. So we provided all the definitions there, and in the pathway, there should be hyperlink taking you to the antibiotic formulary section to choose appropriate antibiotics. Next one, please. Okay, this is for detecting the organism or the UTI in the pregnant woman. There's a change here. So as compared to the previous one, there's a guideline saying that people now there's no requirement to look for asymptomatic bacteriuria in pregnancy. This is a UK National Screening Program guidance, and they say that this is not indicated, and the NICE guideline will be coming in to say the same thing basically. But we have given some exception here. If there's a history of recurrent UTIs, history of upper UTI or pyelonephritis in the past, and unit testing without symptom can be considered in pregnant women. And then the remaining bits are all in self-explanatory how to really look into each part of the UTI pathway. Okay, thanks. Next one, please. Okay, and it's all links with the sequence. Sequence is the commissioning for quality and innovation framework, which is generally mean that we all have to, all the trusts have to take part in the sequence. And there are 5 elements of the sequence for the UTI. That mean, and this time is slightly different because previously it was for 65 and plus patients. Now it's for 16 plus patients. So 5 elements: documented diagnosis of specific UTI based on the clinical signs and symptoms. Diagnosis excludes use of dipsticks in people 65 plus year and in all catheter-associated UTI. That's really important. We don't do that, and we just follow the guideline, not dipsticks on the urine in these patient groups. And empirical antibiotic regime prescribed following the NICE or local guideline, which again in the antibiotic formulary. Urine sample sent to microbiology as per the NICE requirement. Again, that's the definition we just gone through in the pathway. And for diagnosis of COTI or catheter-associated UTI, documented review of urinary catheter use is made in clinical records. So that's all 5 elements they are being looked into because we are required to take part in this sequence. Okay, thanks. Next one, please. Okay, and this is the thing I'm saying that UTI and mortality. So we have been in the past and recently again found to be outlier with the mortality with the UTI. So I did look into some patients, a small group of patients, to see really did they die of UTI as such or not. So I just give you a very brief summary here. 5-6 patients. 3 of these patients had chest infection concern, with 2 being at on the end of life pathway. incidental finding of urinary culture results were used to label them as having UTI, which really wasn't the case. One patient had no mention of urinary tract infection throughout in the notes, but labeled as a UTI at the end due to incidental urine culture result finding. One of the patients likely had sepsis of urinary origin, but he was labeled as a UTI, again, not the right agent diagnosis to document. And one of them had unclear source of infection in one patient, and again, urine culture and things they were negative. So what we concluded as that this was a small, obviously, size of the a patient population, but they don't really reflect the concern that patient died of urinary tract infection. So really, we need to make sure that if patient has sepsis of urinary origin, we write that sepsis of urinary origin, not UTI, and the catheter urines, if there are no symptoms and we tested them, they should not be linked with the mortality because they could be incidental finding only. Thanks. So the next one, please. Yeah. Next one, yeah. Okay, so preventing GNBSI is an important quality priority for the trust. These are like a take-home messages. As Lesley mentioned about the GNBSI targets, it's really important to diagnose and treat UTI and COTIs in time, appropriate catheter care, and minimizing the duration of the catheter being in situ. Okay, the important to take culture on admissions for unwell and septic patient because early diagnosis with bacteremia is not only important for appropriate, in antibiotics and management, but also you can diagnose them at much earlier stage. Most GNBSI are urinary tract infection associated, so it's vital to start appropriate treatment in a timely manner when indicated. Review antibiotics in light of culture and sensitivity results. Next one, please. Okay, so optimal urinary catheter management, as I already mentioned, is essential to prevent COTI and subsequent GNBSI. Urinary catheter, they are devices really. So ANTT, insertion, maintenance, timely removal, all elements are really important. Okay. Trimethoprim, our resistance of coliform to trimethoprim is high, so it's again not a first-line antibiotic for UTIs unless you already have a sensitivity like given on a urinary tract. That's different matter, but empirically trimethoprim should not be used. And in case of suspected upper urinary tract involvement or gram-negative sepsis, nitrofurantoin should not be used as a starting antibiotic or a step-down antibiotic because it's purely a cystitis antibiotic. It won't go anywhere apart from the bladder area, so it should not be relied on or used. Thanks. Next one, please. I just want to acknowledge Akash's work in helping with the UTI pathway and the audit. And the next one. Yeah, thanks very much. And if you have any questions, I think there's, let's see if we have any in the chat box, please.
There are no questions.
That's great. So thanks very much and everyone for attending the grand round.
Would you like us to? We can send the slides out if you would like, Dr. Qazzafi. Yeah.
Yeah, please send the slides out, and you can send my email and Lesley email as well. So if people have any specific question on any part of the grand round or on GNBSI or on the UTI management, please send an email to us and we'll try to reply that. Yeah.
Okay.
Thank you very much for presenting.
Thank you.
Thank you very much. Thank you. Okay. Close it. Bye.